and I am the Minority Health Program Coordinator for the City of Portland. First, I would like to ask you all to please join me in a moment of silence to honor all people who have died due to COVID-19. Thank you. Before we start with our presentation, I'm pleased to inform you that we have a team of 4 CHWs who are ready to provide interpretive service into Spanish, French, Lingala, Portuguese, and Somali in case someone's needed. Just let us know. The Minority Health Program gathered a list of questions and concerns from local community faith leaders, CHWs, from different racial and ethnic groups. Then partnered with Maine Medical Center Preventive Medicine and Maine DHHS Office Senior Advisor to develop the content of this educational session. This session's goal is to enhance acceptance and uptake by building understanding of the vaccine among these communities. I am pleased to introduce to today's presenters, Dr. Renee Wolf and Dr. Lisa Letourneau. Thank you both for taking the time to develop the content of this presentation, as well as to present it. Due to the number of participants, please introduce yourself via chat, name and organization. Please mute your microphones and unmute only if you have questions. Also, we would like to inform you that this session is being recorded. Lastly, we will ask you to please take the time to complete our evaluation form at the end of this session. Welcome and thank you all again for joining us. Now I will leave you with Dr. Wolf and Dr. Letourneau. Thank you, Lisa.
Great, thanks so much, Nelida. Thanks for inviting us to join you all today, and thanks everyone for being with us here. I am Lisa Letourneau. I am an internal medicine physician by background and have done a lot of public health work over my career. Currently serve as a senior advisor in Commissioner Lambrew's office at Maine DHHS. And I'm joined today by Dr. Renee Wolf, who I think many of you know from the Ask the Doctor series. So I'm going to start out with a sort of fly through a, probably not as brief as it should be, presentation, to share some information. And then we were going to make sure to leave plenty of time for discussion and questions, and Renee will jump in then as well. So to start out, we just want to remind everybody that while it's incredibly exciting that these vaccines have been developed to help us end ultimately the COVID pandemic, we know that they only work when they get into people's arms, right? The vaccines themselves don't, the vaccinations do. So we really appreciate the interest and the support from all of you, particularly the community health workers who can help to support community conversations about the vaccine. I wanted to just share a little bit. So I mentioned I'm trained as an internist. I work for the state, but I also do clinical practice 1 day a week. I do substance use treatment at a clinic in Biddeford and see people with opioid use disorder and help support treatment for them. I got vaccinated because of that role and seeing patients face to face there, particularly patients who are incredibly vulnerable to disease. Many have been exposed to COVID, many come out of the jail, live in crowded situations, and wanted to both be able to feel that I could see them in person and interact in a way, because while we do a lot of telehealth treatment, over the computer, being in person is incredibly valuable as well. I also have a 90-year-old mother who still lives at home and is actually just getting her second vaccine today due to one of my sisters driving her an hour and a half to go get a vaccine. So being able to be around her, around patients, is incredibly reassuring. And while we know, the vaccine is not 100%, it's just so important to help provide that level of protection and encourage others to get vaccinated as well. I think it's important to recognize that there are tremendous benefits of the vaccines, recognizing that it protects not only the individual, but our family, our friends, our community, and that while wearing masks and distancing is also, those steps are also important to help reduce the spread of the virus, that ultimately the more people who get vaccinated, the more protected we'll be, and the sooner we'll get back to our communities' regular way of life. In terms of just a little bit of background, how do vaccines work? Basically, vaccines work by encouraging your body to produce an immune response that would normally happen if you're infected with the virus, but in a safer and, in this case, a more effective way. So this little graphic is a picture of the coronavirus that we all know from the many stories in the newspaper that are out there. And the virus has these spike proteins, these proteins that stick out of the virus that both are what enables it to enter the cells in our body and cause the damage and destruction that it does. It's also what our antibodies recognize from the virus, and the antibodies help to block the virus's ability to replicate, to duplicate itself. And so what we're doing with the vaccines is basically presenting a version of this spike protein so that the body thinks we have an infection, produces those antibodies and other elements of the immune response to give us the protection without actually having the disease. A lot of people understandably say, how do we know the vaccines are safe? We know they're safe because they have been studied in very large clinical trials. And clinical trials are when scientists enroll thousands, tens of thousands of people who get the vaccine, and then we see what happens when they're out in the community. Those trials included people of different ages, race, ethnicity, people younger, older, people with medical conditions. And then we study how frequently they get infected versus people who haven't had the vaccine. The data from those trials was collected and reviewed by the Federal Drug Administration, the FDA, and a separate independent committee. And scientists were able to review and make their recommendations based on that. It's also important to remember that the technology, the messenger RNA or mRNA technology that's been used in these first vaccines is not actually new. It's the first time a vaccine has been approved with that technology, but those vaccines were in development for other conditions, including Zika and Ebola, over the last 10 years. So they have been studied widely. And we were able to get these vaccines out quickly because basically a lot of support across the whole globe, including financial support, that allowed for the rapid development and production of those vaccines even before the final authorization was given, so they would be ready to go. We also understandably hear concerns about, well, they were developed so quickly. It was called Operation Warp Speed. Why would we trust that? And again, we know that we can trust the results of these vaccines because, one, we were building on years of experience with these mRNA vaccines, as mentioned, from other conditions. We were able to get trials in place quickly using existing networks. The manufacturing started ahead of time, a lot of financial support. The vaccines themselves are much faster to produce in large amounts than traditional vaccines, which are historically have used the need to grow the virus in chickens' eggs and hen cells, which is not the case with these vaccines. And we also know that the government has prioritized the review and authorization of these vaccines because the pandemic is so deadly. I think it's important to recognize some key facts, which is that the vaccine will help you prevent getting sick from the virus. Even people who have already had COVID, it's important because the vaccine gives more reliable protection. The vaccines itself do not contain any of the coronavirus, so it can't give you COVID, and it won't cause you to test positive on the viral tests. A lot of people ask, well, were people like me in the trials? And the answer is very likely. The vaccines were tested in a very diverse group of people that included Hispanic, African American, Asian, and Native American individuals. About half were older. And throughout all these groups, we did not see significant safety concerns. And they've now been administered to many millions of people, both in the US and now across the globe. The two vaccines that are out there right now, I'm sure you've heard the names from the Pfizer company and the Moderna company, are both messenger RNA or mRNA vaccines. They were both tested, and they're very similar. They were both tested in trials with, again, tens of thousands of individuals. The efficacy, the ability to prevent disease was very similar and extremely high, about 94 to 95%, which again, I think one of the risks here is that we get spoiled by this because that is unusually high. In order for the FDA, the Food and Drug Administration, to approve vaccines, typically you only have to prove the efficacy is 51%, is greater than 50-50 chance of getting the disease. The typical flu vaccine often has an efficacy of about 60%. So to be at 94%, that's just stunningly high, while at the same time being very safe, really very minimal adverse reactions or side effects. Both require a second dose. The Pfizer's at 21 days, Moderna at 28. They have been approved so far primarily for adults. You can see Pfizer at 16 years old. They are both being studied in younger populations, and we hope to have approval for younger people and even children potentially by later this summer or fall. They do require very cold storage, you can see here, so that is a limiting factor sometimes in terms of distributing the vaccine. So we know that getting other vaccines that are easier to handle will be better, as is the case coming up with the Johnson & Johnson vaccine, or J&J, that you're hearing is going to go in front of the FDA this week, later this week. And a lot of people ask, well, what's in the vaccine? Or I've heard that certain things are in it. Basically, the vaccines contain only that messenger RNA or mRNA that codes for the production of the spike protein that then triggers the immune response. Some polyethylene glycol, which is a preservative that's in many other medications and substances that we use in healthcare situations, and then some fats and sugars. Importantly, they do not contain all of these things listed here: live virus, eggs, gelatin, pork, fetal cells. There's been some misinformation campaigns that have said that they include things like a GPS device or a microchip. It does not contain any of those things. It is very safe. People ask, well, if it includes RNA, messenger RNA, will it change my DNA? Is this going to cause problems for my children or my children's children? And it's important to know that they do not interact with our DNA. The messenger RNA triggers the production of this spike protein that the body then again recognizes to create its own immune response, but it does not go into the nucleus of the cell where our DNA is stored, and it does not alter the DNA in any way. One of the reasons why these vaccines require that special cold storage is that the mRNA is very quickly broken down, and so it's packaged in a lipid or a fat sort of capsule, but that capsule is very unstable. And so the good part of that is that mRNA is broken down very quickly after the vaccine gets in our bodies. There's also been a lot of questions about, is it safe in pregnancy or if I'm breastfeeding? And there is no evidence that these vaccines cause any fertility problems in either men or women. And from what we know, we think there's very little risk for women who are pregnant or breastfeeding. Pregnant women were not specifically included in the studies, but because anytime you have a trial with tens of thousands of people, you inevitably have some women who were pregnant and didn't know it. So there have been tens of thousands, and probably more than that now, women who were pregnant when they got the vaccine, and there have been no adverse effects reported. It's also important to remember the trade-off. If women are pregnant, having COVID can result in very severe illness during pregnancy. So it's important to know that the vaccine can help with those risks. We have heard of some issues with allergic reactions, and there is some rate of people developing severe allergic reactions after these vaccines, but it is a very, very low rate. It's roughly 4 to 5 people for every 1 million people vaccinated, which is on par with other vaccines as well. So people with a history of a severe immediate allergic reaction should talk to their doctor. If they have an epinephrine pen or an EpiPen for other allergies, they should bring it with them. People who have more sort of common allergies to medications, food, pets, etc., it is not an issue. They should still get vaccinated. If people had one of the vaccines and they developed a severe reaction, then they should not get the second one, but that again is very uncommon. In terms of what to routinely expect, it is not uncommon to have some minor side effects, particularly after the second dose of these mRNA vaccines, such as headache, muscle pains, joint ache, but these are pretty mild to moderate and self-limiting. They're not uncommon. It's upwards of maybe 20 to 30 people per 100 will develop these symptoms, and it might cause them to miss work for a day or two, but they are much less serious symptoms than actually getting COVID itself. And you will not get, these are not signs that you're getting COVID. They are signs that you are developing an immune response as the vaccine is doing. Usually just conservative treatments like cool compresses over the injection area if it's sore, or Tylenol and fluids if you have fever. Although it's also important to remember that some symptoms like cough or shortness of breath or loss of taste or smell could mean that you just had the bad luck of being infected with COVID around the same time that you got your vaccine, and could actually have COVID, and not from the vaccine, but just because of timing. People also ask, well, how do we know that the vaccines aren't causing long-term side effects? And there's no evidence of that yet, but we are also very closely watching people. So there are two federally developed adverse event monitoring systems, one called this VAERS, or VAERS, and the other VSafe, which is people individually can track their symptoms and report on their own smartphone. So there is considerable attention to monitoring for safety issues so that we can track and identify those if they do occur. People often ask, how long after I get vaccinated does the vaccine take to work? And it's typically about 2 weeks to be fully protected, although people do have some protection after the first vaccine of these two-dose vaccines. I mentioned people could get infected just by bad luck at the time they're getting vaccinated. So it's possible somebody could still get COVID only because of that bad luck and timing, but not because the vaccine is causing the infection. We don't really know yet how long they will provide protection. We're hoping, many months, but we're going to have to wait and study this over time. There's also questions about, well, could we still pick up the virus and transmit it to other people, even if we don't get sick? And that is still something that needs to be studied. I believe there were some studies just released this weekend that suggest that it can be helpful with limiting transmission as well, but we need more time to look at that. We also get the question, well, why would I need to what's the point in getting a vaccine if I still have to wear a mask and stay distanced from people? And the bottom line is getting vaccinated is the best way to prevent getting sick with COVID, which, as we know, can be a very serious and sadly a deadly illness. It also helps to protect the others around you, and really truly is the fastest way to help us get back as a society back to normal. People have asked, do I have to pay for the vaccine? The answer is no. You do not have to pay for the vaccine. If you have health insurance, you may be asked for that because the vaccine clinic can charge the insurance company for the cost of administering the vaccine, but you should never be turned away for the inability to pay, and you should never be asked to pay for the cost of administering the vaccine in the clinic. The clinics can either bill insurance or HRSA or even other federal agencies. You can get a vaccine even if you don't have health insurance, a driver's license, or a social security number. And also important to know that it will not affect your immigration status. Getting the vaccine does not change whether you can stay in the US, get a green card, get public benefits, and it will not impact your immigration status. So with that, I'm going to encourage you to complete the session evaluation. Nelida would get after me if I didn't say that, so we will make sure. I think you have the link as well. We would love to take questions now, and I invite my colleague, Dr. Wolf, to jump in with any other comments before we jump into questions as well. Renee, anything you want to say about either your story or anything that I've missed?
Sure. I think the first thing I want to say is I'm incredibly impressed that you got through all of that information with having packed so much into it and given so much and done it so well. So kudos to Dr. Letourneau for that. I thought I would just add a couple of things. One, for people who don't know me, my name is Renee Wolf. My background is in surgery, but as part of a master's in public health, I've joined the Division of Preventive Medicine at Maine Medical Center, and I have been involved with the Ask the Doc series, which is a way to have a sort of a town forum with questions and answers through Zoom with community members. Some of the people on this call I recognize, and hello to you and hello to everyone else. And I thought I would just add a couple other things. Like, for example, this is, as I think everybody knows that the pandemic is evolving. The information that we have is evolving, and it will change. And I think that one thing that's important is to just be really flexible and to have people understand that we're still learning. People often ask about the complications. And one bit of good news is that the complications that we see with the vaccines have been as expected, that they're low, they're rare, severe reactions are very uncommon. And as now pretty close to 44 million doses have been given in the US, those rates have not really changed. So as we learn more about the safety of the vaccines and about the things that happen with the pandemic, I think it's important to sort of relay that information. And I thought that I would also add that just some tips in terms of talking about vaccines with the people that you might interact with. I think I use analogies a lot. I talk about the pandemic as a speeding train and the vaccine as the brakes. The faster the train is going, the longer it takes for the brakes to slow the train down. That's an analogy that works for me. I talk about the variants as mutations, as sort of, if you're typing a paragraph really fast, a lot of times you'll have more typos that might change the meaning of the words. And I can talk about some of those things, but I think storytelling and the use of analogies is really important. And I would encourage any of the, as you talk to people, to tell your own story. I know why I was looking forward to getting vaccinated, and I know I was excited for my parents to try to get vaccinated. For me, vaccination is really a message of hope, that that means that there's a sort of a light at the end of the tunnel, that we may be able to get back to a more normal life. I'm hoping that in some ways it won't be the pre-pandemic normal, that we might have actually learned a few things. I think it's also the concerns that we hear, whether it's about the vaccine safety or about people who are concerned about when the timing of the vaccine, et cetera. I think those are all really important concerns, and they usually come from some context that is really important to understand. So sometimes I can sort of figure out where people are coming from, and sometimes I just have to ask, what is the nature of that concern, and how can I help alleviate that concern? And really encourage people to get good information, because I think there's a lot of different types of information. And I think that the community health workers in particular are such an important source of information and can lead people to other sources of good information. And I think I'll probably leave it there.
Great. Well, thank you, Renee. And those are really great points. And I love the speeding train thing. That's terrific. So thank you. And the typing quickly. Gosh knows I make a lot of mistakes quickly. So there are many questions in the chat, I see. We can start sorting through those, or I don't know, Leanna,
Sure.
as a monitor.
Yeah, I can read them out and you can just respond. So first one is, are vaccines currently approved for pregnancy and breastfeeding for women who are pregnant or breastfeeding?
Do you want to take that, Renee? You're shaking your head.
Oh, at the moment, the simple answer is yes. If you are pregnant or breastfeeding, you can receive a vaccine. The recommendation is always check with your OBGYN or your doctor if you have particular concerns, but the answer is yes.
How long after someone tests positive for COVID-19 could they receive a vaccine, or should they receive a vaccine?
So I'll take that one. So it's really any time after they've passed the acute infection phase, which is typically described as completing their 10-day isolation period. So any time after that, it's fine. There's some language out, I think something posted on the US CDC website that it said in times of vaccine relative scarcity, if you're trying to prioritize that people who have had the vaccine are likely, had the illness, are likely to, have a high level of immune response for 90 days. So if you need to deprioritize them, but generally we're just saying anytime after you're done your isolation period.
Do they ask for any sort of identification at clinics to prove age or residency in the state of Maine?
We are asking clinics to ask for that now. As you've seen from some of the headlines, I'm sure there's been some, not always great behaviors by people driven by fear, driven by scarcity. So we as Maine DHHS recently did define what we mean by residency, which is really anyone living in the state of Maine who intends to make Maine their home, even if they're coming in for work or an intention to work. So we do ask clinics now to ask people to show some evidence of residency, whether that's a license identification card, a bill, or a piece of mail with their name and address on it. And then age, same. We would ask folks to again show ideally something with their birth date, though we recognize that that is not always available for everyone, and we do encourage vaccination sites to use their discretion, what seems to make sense for that person.
If you have allergies and are hesitant, should you go to a hospital for injection in lieu of going to a pharmacy or a clinic, perhaps in a parking lot?
That's not a bad idea. I think that, again, most allergies, if you have food allergies or allergic to other medications, if they are not severe, are unlikely to create a problem with these vaccines. But if you have a history of severe allergy, particularly if you carry an EpiPen, meaning you've had a severe, even anaphylactic reaction, then your risks are somewhat higher. And it's probably not a bad idea to be someplace where people can keep a closer eye on you. All vaccination sites, including the commercial pharmacies, are supposed to observe people directly for 15 minutes for everyone and 30 minutes if they have a history of allergy. But that might be a little harder to do if somebody's in a busy store or a drive-through site. So if you do have the option of getting it in a hospital or a clinic where there's better opportunity for direct observation, that would probably be a good idea.
Can I just add a little of the data? The allergies that are associated with higher risk are really these severe allergic reactions, and usually a history of severe allergic reaction to a medicine, not so much history of allergies to like milk or latex or other allergies that might be more common, not food allergies or environmental allergies per se. And in the first 2 million doses of the Pfizer vaccine, for example, and the Moderna vaccine has a very similar profile, in the US, there were 21 severe reactions, 17 of which were considered to be anaphylaxis. So it's about 1 in a million. And those all occurred within, the average time for the reaction to develop was 13 minutes. So the severe reactions are really rare and they occur very early. And that's just to sort of put a little perspective on it. And if you have any questions about whether your type of allergy puts you at risk, ask your community health worker, ask a doctor, ask somebody if you have concerns about whether the location is appropriate for you. But for the vast majority of people that have the vast majority of allergies, a vaccination site that is, you know, any vaccination site will help. We'll be okay.
Are there any medications being developed to treat COVID-19?
Absolutely, yes. There are, you might have seen in the news early on, there were discussions about medicines that didn't really work, but others such as remdesivir, or now there are several monoclonal antibodies that, if used early on in the course of disease, before people are, you know, very sick, can help. There's also been use of steroids. So that is probably not my best area of expertise. I don't know, Renee, if you have more in terms of the specifics, but there certainly has been progress and, you know, real options for people who are sick with the disease. Although it's always better to avoid the disease.
Well, that's, yeah, I think if an ounce of prevention is worth a pound of medicine. But when I think about it, I think of medicines that are intended to deal with the virus and medicines that are intended to deal with the consequences of being infected. And some of the consequences of being infected, whether it's pneumonias or, you know, injured lungs or injured hearts or injured kidneys, or some of those things that we see and people get really sick, are very similar problems that can be caused by other diseases. So those we sort of know how to treat. Once we got an idea of how this infection acts and works in bodies, then we can sort of treat them the way we've treated similar problems from different causes. In terms of antivirals, there's a lot being developed in that arena as well. But I think that if you know, we've learned, I think, well, not we, but the people who treat COVID have learned a lot about how to try to keep the severity of the disease in check. And that's sort of a constant, there's a constant effort to find new antivirals and new ways to treat the disease that is associated with the viral infection.
Great.
Is the vaccine effective in protecting against any of the variants?
Yes.
Yes.
Yes, absolutely. That is a much longer conversation. And as you all know, probably from seeing the papers, there are many variants out there. There's probably more than, you know, we've even documented here. And they are not unexpected, as Renee gave such a great answer about, you know, typing quickly. The virus, whenever it replicates quickly, duplicates quickly, some mutations are going to happen and you get the variants. The data to date would suggest that the vaccine, certainly the two that are out there, have some pretty good level of effectiveness against those variants, although at the time that the trials were done, those variants largely, you know, were not out there. So it's a little bit hard to know. One of the issues about this newest vaccine, the Johnson & Johnson or J&J vaccine that's going in front of the FDA this Thursday, people see the headline that the effectiveness was somewhat less than the two mRNA vaccines. It's about 74% versus 94%. But part of the issue there is that it is out there among a different world that now includes variants. But remember, 74% is still very good. It's still very good in terms of performance. And also that vaccine and others have helped to avoid the most serious consequences of COVID, including hospitalization and death. So yes, still very good. And Renee, do you want to add on to that? I saw you giving a vigorous nod.
Yeah, no, I think that, so both Moderna and the Pfizer vaccine are expected to be effective against the UK variant, which is the variant that is causing concern at the moment. But I think it also underscores a couple things. As long as the virus is out there replicating, there is the opportunity for more variants to develop, because the faster it replicates, the more typos it'll make, the more variants that might occur. And that's what mRNA viruses do. They replicate, and they replicate a lot. And so I think it's almost as if there's a race. Can we get people immunity? Can we get them vaccinated? Can we get them protected before the variants become too dominant and too present? So there's kind of a race between the variants and the vaccination, and we're hoping that we're making progress. I think Dr. Shah a couple weeks ago said, as he looks in the rearview mirror and he sees all the numbers coming down, it's really, really hopeful. But as he looks ahead and he sees these variants taking hold, he has concern. And I think that's a really good way to look at it. I think the other thing that's important to know is that with the mRNA vaccines, because of the technology and the way that they're made, there is an opportunity to tweak them to be effective against variants. And so that is a potential benefit that has been discussed, which means that there's a possibility of developing boosters against the specific variants because of this technology, which I think is really, really cool.
And not unlike what we do every year with the flu vaccine, right? The flu vaccine, the flu virus mutates even or changes even more quickly. And so we every year make a new vaccine for the variants that are out there that year of the influenza virus. So not something we're not used to, and certainly something that could be done. And again, as Dr. Wolf said, because of this particular technology of the mRNA, we can do it even faster with these. So that is really fantastic news.
Is the vaccine safe for older people with heart disease and/or diabetes?
Yes.
And
yes.
A lot safer than getting COVID.
Thank you. Yes, and older people were included in the large trials, and people with chronic conditions. We also, you probably have made a priority of vaccinating older adults first in the country and in the state. And so now we have had tens of thousands, actually hundreds of thousands in this state and millions across the country of not only healthcare workers, but now, older adults. And we're not seeing, any adverse outcomes related to that. And as we know, as Dr. Wolf said, the death rate in older adults is frighteningly high. I believe in Maine, the numbers were something like 94% of all deaths in the state occurred from people who were, it's either 55 or 60 and older. So the alternative is not good.
Are there any risks if you do not respect the time in between the two vaccines, in between the two doses?
I'd say potentially, because that's how they were developed and studied. So, as noted, the Pfizer should be given at least 21 days apart, and Moderna 28 days. There is some wiggle room there. Generally, it's felt to be about 4 days on either side. US CDC has now said if it's impossible to vaccinate somebody at their recommended time frame, you can go out longer, and they've actually said up to 6 weeks. But what we know is what comes out of the studies, and I think to everybody's benefit, staying as closely to those recommendations as possible is best. Although if something happens, they just can't, and needs to be longer, then that can be accommodated.
And Dr. Letourneau, if I can just ask for a point of clarity, is that concern about risk, or is that concern about efficacy?
I would say efficacy, right? Good point. I'm not aware of any particular risk other than it not being as efficacious if you're not giving it the way it's recommended. Renee, did you want to jump into that?
I think that those are the recommendations at the moment, because that's what the studies have, shown us, that you get. The vaccines were sort of designed for maximum benefit. And so we know that if you give them at these time frames, the 21 days and the 28 days, that's when you are likely to get maximum benefit. Adjustments to that schedule will have to be shown to be, will have to be proven with the data. And that data is not there at this point in time. It may change. There's been a lot of discussion about do you need a second dose? Can you delay the second dose? I don't think there's the data to support not following the protocol, although we know that if you just sort of in the common sense test, there may be some adjustments that will come in the future. But at the moment, that's the schedule that we have the data on. And yeah, and it would not be related to risk because the vaccines are relatively low risk. It would be related to efficacy.
Is the vaccine going to be a regular annual vaccine like the flu?
We don't know yet. Yeah, we don't know yet. I think, from the comments we just made about variants, I think it's entirely possible that we will need a booster, as the vaccine continues to change, as the virus continues to change, but we don't know yet.
I think that also speaks to, I'm just going to add that also speaks to what's the long-term protection. So we're learning about how long the protection is and what the differences are between the protection that you get from the vaccine and the protection you might get from natural immunity or from having had COVID. In general, protection that you get from the vaccine is considered more reliable because everybody gets the same dose and we can study it long-term. And the protection that you might get from having COVID will depend on how much virus you were exposed to, how significantly you were affected, and what your immune response is. There's a lot less predictability with the natural immunity, but we know that from the immunity that you get from the vaccine, so far, people are good for about 9 months because that's how long it's been going on. And there are expectations that it will be longer, but that's some of the information that will come with time. And as will, do we need a booster? At what point in time? Will there need to be, a regularly scheduled thing? That's information that's actively being gathered, but that we don't have yet.
We're hearing a lot about the pros of getting the vaccine, but can you also discuss whether there are any cons to getting the vaccine or risks associated?
Well, the risks really would be, as we talked about, the quite rare risk of a severe anaphylactic reaction, although even that can be treated, with medicines and turned around quickly. There are the relatively minor side effects, but I wouldn't, again, compared to the risk of a COVID infection, severe infection, and even death, just not even in the same ballpark.
Dr. Letourneau, can you clarify? Someone thought that you said that somebody who had taken the vaccine should quarantine for 10 days. I think they were just asking for clarity in that statement.
No, sorry if I was unclear about that. No, there's no need for quarantine whatsoever after somebody receives the vaccine. Again, there's no live virus, there's no viral shedding, anything like that. What I was trying to answer, somebody asked, is there a time period after which you are infected that you should get the vaccine? And I said, you just should be out of the acute infectious period, which is generally the 10-day isolation period. So if you've had COVID, finish your 10-day isolation period, and then it's fine to get the vaccine, but nothing after the vaccine itself.
And maybe remember also that you're not fully protected till after the second dose, and it's around 2 weeks after the second dose. So if you're sick with COVID, wait to get the vaccine and talk to your doctor about the timing. And then just when you are getting the vaccine, remember that full protection from the data that we have to date is about 2 weeks after your second dose.
Great, thank you, Renee. Yep, great clarification.
If you've had the first dose of the vaccine, are the chances of getting infected with COVID-19 the same as someone who has never had the vaccine? So how effective is it after only the first dose?
Some protection. I don't know. Renee, were you leaning forward to take that one?
No, I was just probably going to say the same thing you were going to say is, yeah, you've probably got some, but we don't know how much because it hasn't really been studied. There is sort of ongoing research as to what exactly is the level of protection after one dose, but I don't think that we have any studies that are robust enough or big enough to really say anything definitive about it. So the bottom line is you should still socially distance, wear a mask, and do all the same sort of protections before the first dose, between the first and second dose, and probably after the second dose until we understand how it affects your ability to transmit it to others. Even though your ability to become infected and sick from the virus might be less, we don't fully understand what your ability to transmit it is. So the current recommendation is still use all the same precautions to protect the ones around you, even after you've been fully vaccinated.
What else can you tell us about the Johnson & Johnson vaccine? When might we see emergency use authorization, and will it be distributed in the USA?
Yeah, very exciting this week. So the 26th, I believe, is the date, which is this Friday. The manufacturers are scheduled to go in front of the FDA, and if all follows as it did with the other vaccines, it would generally then go to the independent committee for review a few days after that, and possibly be authorized. And just to be clear, right, that and you said the right word, Liana, these vaccines have emergency use authorization. They have not received yet full approval because that process is longer, many months, and that will eventually most likely happen, but they will likely get emergency use authorization if the data looks as good as the initial press release, which is all we have so far. And there is vaccine ready to be distributed, although from information I just heard this morning on the news, apparently it's going to be a little bit slower coming out initially. They're aiming for many millions of doses, but initially it's probably going to be a little bit on the slow side. But we expect to think at least several tens of thousands of doses in Maine, if again all goes well and gets approved within the next, possibly even next few weeks.
Are antibiotics effective for COVID-19? Some communities are using medication like antibiotics, ibuprofen, and other home remedies.
Not antibiotics. No, antibiotics by definition work against bacteria. And this is a virus. So unfortunately, antibiotics do not work at all against viruses, including the coronavirus that causes COVID-19. You mentioned ibuprofen, Tylenol, just symptomatic medications could help with things like fever and chills and achiness, but don't actually, sort of, as Dr. Wolf was saying, the things that the virus, causes versus the virus itself.
Is there a supply of monoclonal treatments in Maine?
Yes. So the federal government has been making those monoclonal antibody therapies available. To date, they've distributed some directly, and as a state, we've directed them to the 4 large hospitals in the state, which then share them with other hospitals and providers. But over the last just couple of weeks, the federal government has made those available by direct order from provider organizations and pharmacies that want to order them. There's actually more available right now than has been used, largely because it's a tricky process to identify somebody early enough in the disease who's high enough risk that it merits using them, and then getting them to a place where they can get the 1-hour infusion. But certainly, issues that can often be figured out. So if you know somebody who's at high risk, particularly older adult or high body weight, that puts them at higher risk for adverse outcomes, please encourage them to talk to their doctor as quickly as possible, or go to their hospital emergency department, because those therapies are available and they've been somewhat underused across the country.
If someone has had very bad side effects to a flu shot, should they still get the COVID vaccine?
Yes. I'm not sure what the side effects to the flu shot, are being described, but this is a totally different vaccine. If it were a severe anaphylactic reaction to the flu shot, then they, should report that and have an EpiPen, but that is pretty unusual as well. So generally, I would say yes.
If you get sick with COVID in between your first and second dose, would you have to start all over again?
No, the recommendation is to go ahead and finish the series, but you don't have to restart it.
What's the best way to get a vaccine in Maine? Can you outline different ways that it is available to people who may not have primary care providers or a connection to the healthcare system?
Sure, and if I can share screen for a minute again, I will just show folks where that information is on the state website. Just sorry, this again here, wrong thing I had. So the state has a website, the governor's website, that has lists of all the COVID vaccine sites, and it is right here from the governor's website, and we can put this into the chat. That has a list again by the name of the clinic, and it has the town or municipality and the county. And every one of these has a phone number and or a website where people can access that. Some primary care practices have been included, but mostly it is through hospital-based clinics. Although now also you can see here Walmart. I think it's 36 or so of the Walmart stores, and then it's been announced that some number of Walgreens stores will also be booking appointments. All of the Walmart are accessible through a website. But again, all that information is on the state website, which I'm just going to put in the chat to everybody here. We understand that it might not always be easy to access phone or the online systems, and there are several organizations that have been helping work with people who have difficulty navigating those sites. So I would encourage you all to be talking in your communities about ways to help people who might otherwise have difficulty navigating those sites.
Are there ways to prioritize those who may have underlying conditions, who already qualify because of age, but may have underlying conditions?
So we certainly would encourage, when primary care practices know their patient populations, encourage them to be in touch with individuals who might be, 70 and older, but even more risk because of underlying chronic conditions or older age. I don't know, other that the large clinics have different efforts underway. Liana, feel free to jump into that one yourself in terms of maybe what some of the AAAs are doing, the area agencies on aging or others.
I think the only thing that I would add is you're right, certain providers are certainly doing it differently. They're all respecting the tiers. So obviously they have to qualify under 1A or 1B for those who are 70 and older, but different providers are working differently to prioritize either some of them it's folks over 80, for some of them it's folks with underlying conditions that they know of. So it's a bit of a case-by-case basis based on the provider about how they prioritize within the vaccine that they've within the allotted tiers. Another question is whether you know anything about a vaccine coming out of Germany.
I wonder if that refers to BioNTech. So Pfizer partnered with a German company called BioNTech to make their vaccine. Other than that, a new vaccine or separate one. I mean, a lot of these, there's a lot of partnerships that exist, but BioNTech is that may be what that refers to. I'm not sure.
If I've already gotten my COVID vaccine and I travel to South Africa or England, would I be protected from the new variant?
Hard to know. And again, the data that's coming out, as Dr. Wolf mentioned a few minutes ago, we really don't have large scale data from Pfizer and Moderna yet because on those variants, because the big trials happened before the variants really existed. The newer one, Johnson & Johnson, we have information about how well it performed in different parts of the world, which would suggest, different performance in areas where there are higher prevalence of the variants. So hard to know, although, I think the data we do have to date would suggest people are protected from severe illness and hospitalization with the vaccines that exist. But probably, global travel right now is not being generally encouraged anyway.
I think if there was, I would agree with Dr. Letourneau. I would discourage global travel, but obviously if it's necessary, I would just continue with all the precautions, assuming that I could either, if not get it, then transmit it. And I would continue with all the same precautions.
Good point. Thank you.
We only have a couple of minutes left, so I'll try and speed through the remaining questions. One of them asks, may actually be for you, Nelida, is the city planning to have a clinic to vaccinate undocumented people?
Thank you. Just to remind you all that the City of Portland, the Minority Health Program posted a flyer a couple of weeks ago. Last week we translate a flyer. We will do it by population target. So at this moment we're working with population from 70 above in collaboration with Maine CDC. I just wanted to highlight the fact that we are all collaborating together to ensure that all our minority community members are getting vaccinated. So for this stage, which is 70 and above, the flyers have been created and in collaboration with different organizations that includes hospitals and including Greater Portland Health, Maine Mercy Hospital. We have a plan where there is a list that through our CHWs from different organizations, we can get a list. I have been sending directly to the hospital, or recently we have, with the collaboration has been created a registration form for people. This is only, just to clarify, this is only for people who for some reason haven't get a vaccine, they're 70 and over and have already registered in different sites, but they haven't have an answer. And so when the plan is for the extra doses, who for those who are still in need to get vaccinated, we can send those lists that are provided by our CHWs to these two. And at least at this moment, I'm working only with Mercy and Greater Portland Health, but also there is the city in collaboration with Mercy Hospital and MERC and Maine, and they have been posting a vaccine clinic right now at Portland Housing Authorities. And so what we're going to be doing is, starting this week, the CHWs can help with the registration process for those who are, again, are in need for a vaccine, but it's only for people who are 70 and above. So we can, if you have someone who is in need for the vaccine, just let me know if or your child know, and we will ensure to get that. Again, as Dr. Letourneau mentioned, undocumented status is not a barrier. We have been advocating a lot for this since the COVID started. We ensure in collaboration. No, it's only one program cannot do it alone. The state has been granted a coverage for testing, diagnosis, now for vaccines as well. So that is not a barrier. CHWs, you are a role model. You have to get vaccinated. Please pass the word around. Let your community know that you have vaccinated. The vaccine with this training, the goal was to ensure that this information comes not from me because I'm not a doctor. It comes from the doctors who have been working in this specifically topic, and they're now letting us know that the vaccines are safe. So it's save lives. So take your vaccine, then share it with your community, and let them know that it's safe, and let them know that we are here to help them to get vaccinated in any way. Thank you. And thank you, Dr. Letourneau and Dr. Gold, for making the time to prepare this presentation that is exclusively meant to address the community concerns from this local community. It didn't come from outside. These questions were provided by community members, by CHWs, by natural helpers, you name it, from the community, from Greater Portland Greater Portland area. And also, Dr. Letourneau will be presenting in 2 other sessions. For those, you can tell people if for some reason they weren't available to be in this presentation, they can attend on the 22nd on March night as well. This presentation will be for people up north. But thank you so much. It's 12:02. I just wanted to highlight the fact that we appreciate your support, and together we can make our community safe. Please also take the time to fill up and complete the form, the evaluation form, so we can improve anything that you think that is needed, or any support that you think that we can be, in need for. Thank you.
Excuse me, I forget to
Nelida.
ask one question that wasn't covered.
Unfortunately, we have a hard stop at noon because there's another meeting right on this Zoom line. So perhaps you can share that question with Nelida and we can work to get you an answer offline.
So sorry about that, but thank you. And thanks